Dr. Heffernan, welcome to the Nailed It Ortho podcast. So happy to have you on, and especially happy to have you on because you're actually one of my attendees, and I've worked with you personally. So thank you so much for being a guest on the podcast.
I appreciate it, guys. Thanks for the invite.
And we typically start off our podcast with just a couple of questions, getting to know you a little bit better, and then we transition into the case for the day. So our first question is kind of the age-old question for there may be some residents listening that are trying to figure out what field they want to go into. What made you choose the field of pediatric orthopedics?
Well, I entered med school, and I thought I was going to be a pediatrician, actually. So my favorite classes the first 2 years were anatomy, and I liked actually cardiac physiology. So in third year, we had one elective. I was scheduled to do pediatric cardiology. My first rotation was peds, and I liked hanging out with the kids. I didn't necessarily like what the, sort of like the daily tasks for the pediatricians. And so my next rotation was general surgery. On the trauma service, the intern that was I was assigned to was an ortho intern. So on a slow day for general surgery, he got me into some ortho cases. I love those cases. Pretty much immediately switched my elective from peds cardiology to peds ortho. Did that, let's say, January of my third year, fell in love, and haven't looked back.
That's awesome. That's why I always take a little extra time with all our students that come through, no matter if they're interested in, they know they're interested in ortho, or even if they're saying, hey, I'm thinking about going into medicine. You just never know how things might turn out if, they get into one of those cases, like you said, and just realize like, hey, this is pretty cool. And
well, I think the opposite is true too. So meaning you could be dead set on ortho in your first couple of years, and then it's important if you're a med student that you sort of keep an open mind. Same thing for residency. I thought I was going to do, honestly, I thought I was going to go into sports medicine. But sort of approaching each rotation, keeping an open mind, sort of identifying what you like about it, what you don't like about it, and then kind of reassessing what you see yourself doing in the future. And I know a lot of people, at least from my medical school, who entered third year with one thing in mind, ended up falling in love with something else. So I think it's important to keep an open mind.
I like your style, Dr. Heffernan. I don't know. That's what I tell everybody, but truth of the matter is, I think when I entered into med school, I could have told you I was going into ortho. And I'm still figuring out this fellowship thing, but I feel like I'm probably going to go into what I said I was going to go into like years ago. And but like you said, I try my best to keep an open mind. It's just, I always
I like your style too. You didn't quite mention what that is.
He's smart guy. Taught him well.
Right. I don't know. I guess I never really said what I'm interested in on the podcast.
Oh man, is this the big reveal?
Yeah.
So am I your Barbara Walters, man? Am I about to make you start crying?
Hey, I'm getting a little teary-eyed over here. No, but things are still in there. I have a checkoff list, and there's two things that's still in there. Like I've pretty much narrowed off every other subspecialty. The only thing that's left is spine and adult reconstruction. So
there we go.
If you guys follow me in a couple years and I didn't end up into one of those, hey man, something changed. Look at that.
Well, but we just got done saying that we should keep an open mind. So even if you go back on this, I think that's reasonable, because that means you found something else that you were into even more.
Absolutely. So we'll see. And let's see. So second question, just so that our fans and listeners can get to know you a little bit. What are some of the things that you like to do outside of medicine or outside of ortho?
Well, currently the thing that I do most is hang out with my girls. So I have a 4-year-old and I have a almost 2-year-old. My younger daughter turns 2 in December. So, I mean, practically speaking, outside of work stuff, I'm basically watching Trolls World Tour, and today we were trying to figure out how to hit a softball, getting frustrated. My older one was getting frustrated with that. I was just putting my kids to bed. My younger one fell asleep, then woke up crying that she had poo-poo in her diaper. So I changed a lot of diapers. And but outside of that, I like sports. So if I have free time to myself, I'll probably go for a run, try to shoot some hoops, something like that.
That's excellent. I think it's always good to find things outside of medicine. Just like you said, some sports is for you as big thing as your daughters, and that brings you joy after working with you. I know their names and everything. I'm not gonna say them now, but I know they bring you joy. So let's go ahead and transition, if we can, into our case for the day, and then we'll talk a little bit about pediatric femur fractures. And we have a case that we just kind of came up with here off the spot. So say a 7-year-old female came in to the ED with a noticeable thigh deformity after having a fall off a swing, and they've been unable to ambulate since the injury, and your resident calls you and says, oh, they have a femoral shaft fracture. What are the things that residents or even attendings should be on the lookout for when you're evaluating these patients, whether they be 7 years old like our case, or we can also cover the infants that come in with femur fractures as well?
So I guess one of the key things you want to know, our treatment, and going off your guys' slide, our treatment is based on age, at least, sort of like the classification of how we treat, at least the initial approach to it is based on age. We already said the mechanism, we fell off a swing. One of the things that you have to sort of be on the lookout for and stay out of trouble with is you want to make sure that the mechanism fits the injury. So falling off a swing, twisting your leg, or falling awkwardly, that makes sense for a femur fracture. But say, for example, the same 7-year-old girl was just, sort of walking or running in her backyard, and she fell to the ground and couldn't ambulate, and was then, came in and was noted to have a femur fracture. You'd have to be a little concerned that perhaps there was either a process going on that was weakening her bone, or perhaps there was a lesion in the bone that would make the bone a little weaker. So those are some of the things from a mechanism standpoint. If you have a high energy trauma, it makes sense that you'd have a femur fracture, but I would caution folks to be aware if somebody has a mechanism that doesn't really make sense for the femur fracture, you might want to look into the quality of the bone, or to really critically analyze the x-rays. It's not that that's that common, but it certainly has happened that we've picked up on some bone lesions over the years. So those are the kind of things that I want to make sure when I talk to the resident initially that we've kind of covered. But as of now, it sounds like 7-year-old fall from a swing. We think she has a femur fracture. That sounds good. My next question is going to be, what else is injured, and what was the exam for the rest of her body?
Yeah, and I think, like you mentioned it in passing, like that's one of the special things about this population. Like they're kids, and at times they don't talk yet. So you have to really key in on what's going on, and you have to play play detective. I guess we always kind of have to play detective, but in this way, even more so, just to make sure that all the pieces fit for what you're actually seeing in the ED, in the emergency room. So I'm glad that you mentioned that. So on physical exam, what are some of the things that you're looking at when you see these kids, as far as, are you looking at their skin, and is there anything else that we should just key in on just to make sure that we're not missing?
So if it's a higher energy trauma, obviously you want to run through, primary survey, secondary survey. You want to make sure that there's no other injuries. Open fractures, sure, very uncommon, but certainly you want to look at the skin compartments. In theory, you can have a thigh compartment syndrome. But really, I would say the main thing is just to rule out other fractures. So, again, it's not that common, but you can also fracture tibia at the same time as your femur. You can have a femoral neck fracture. You can have an injury to the knee. It's a little difficult to get a good knee exam when the femur is not intact. So, more observation there and the best knee exam that you possibly can get. But again, ipsilateral additional injuries is probably the thing that for a 7-year-old would most want to have covered to make sure that there's nothing else that we're missing.
Now, I want to spend a little bit of time because, we made our case for a 7-year-old, but a lot of these that come in are 2-year-old and 1-year-olds, or, patients that can't really speak and tell you exactly what happened. And we know one of the big things around, sometimes with pediatric femur fractures is non-accidental trauma. So what are some of the things, as part of our history and physical, or things that will kind of clue us in towards doing a workup for non-accidental trauma?
So the age that you really kind of want to be concerned about for non-accidental trauma is under 3. 2 is kind of commonly reported, but technically, according to like the AAOS clinical practice guidelines, it's age 3 that we should, have our ears perked up about that, and especially kids who are not walking. So, I think the rate is something like maybe 15% or 10% under the age of 2, and 75% in at least one report, if it was before walking age, could be related to non-accidental trauma. So it's one of those things that for the younger kids, we have to sort of make sure that we're consulting the right people. And in my hospital, what it is that pretty much everybody under the age of 2, not pretty much, the rule is everybody under the age of 2 with a long bone fracture, we automatically consult social work. And, from an orthopedic standpoint, I kind of think that, each hospital should have a policy, or an orthopedic, if the hospital doesn't have a policy, an orthopedic department should have a policy. And then the residents, for example, should be made aware of that, because I've certainly been called, by a resident and sort of get the story where, it's a 1.5-year-old, really nice family, quote unquote, with a femur fracture. I don't think that, we should be judging, whether it's a nice family or, whether they look like somebody that wouldn't abuse their kids or somebody who would. I think sort of using these age cutoffs and being, sticking to that criteria is probably the best way to keep the kids safe, and also not to sort of make assumptions about patients and their families.
Right. And like you say, you can't just assume automatically that, oh yeah, they seem like a nice couple. I'm sure they didn't do that. But yeah, you have to kind of keep that suspicion until proven otherwise, for sure.
Well, I say that for the nice family, but also, for the family that, maybe they woke up and they were in their pajamas and came straight to the emergency room and they don't look as put together. Let's not assume the opposite. So it's one of those things that I think having those age criteria is kind of the best way to approach it.
Yeah, it works both ways. And along with that, I'll even say there are times that you can go in the room and just feel that it's off too.
Yep, I agree.
I know Cody, or sorry, you guys call him Wendell. I call him I call him little baby brother Cody. But
okay.
after you if you've seen, as like a resident, when you're on call during the summertime or when it's hot out, I mean, you get these kids, you might get 15, 20 kids in a night. You do it over and over again. You kind of get a sense for when you walk in the room, just how things feel. And I remember really clearly, like one time I walked in the room, it was a fracture, something like this. And I mean, it was just off. None of it made sense. The way mom was acting didn't make sense. The way dad was acting didn't make sense. It was just off, and you can just feel it. And it's good to, make sure that the appropriate protocols are in place so that you know who to talk to make sure that things are worked up appropriately. But I think we did. Oh, and are there any specific fracture patterns that you should look for with these in the femur as well? Anything like transverse femur fractures that may cause more issues? I think distal, metaphyseal, and things like that.
Yeah. So the ones that, if you're looking at general shaft fractures, transverse is most associated with with abuse. And I think when I was in training, the teaching was actually spiral, but there's been additional studies that have come out that, sort of have pointed us in the direction towards transverse. And then there's some specific fractures that are more concerning for abuse, and those are corner fractures or bucket handle fractures, which are kind of the same thing. Basically, that's an avulsion of the metaphysis that's right adjacent to the physis or the growth plate. A bucket handle fracture is essentially a bigger version of a corner fracture, but those are also ones that we'd have to be weary of.
And in these patients that, they come in, it's a 2-year-old or, a 8-month-old with a transverse femur fracture, do you typically get a skeletal survey as well? Like when in our workup for non-accidental trauma, is that with every patient? Is that with some? How do you work that out?
So the social work consult is with every patient, and the skeletal survey is based on concern either of the emergency room physician, social work, or if a discussion amongst everyone thinks that it's warranted to pursue further imaging. So it's not that every single one of those patients gets a skeletal survey, but at least at our institution, but every single one gets a social work consult.
Okay, good. Yeah, it's good to know. I always thought it was just like we were mentioning, just having the protocols in place to like, hey, when you see this, there's a chain that these things have to go up the line to, and you explain it to the patient like, hey, we're not necessarily saying that you did anything, but this is what we got to do when we see these types of injuries. So I think that's always very helpful, and it keeps the kids safe for sure. So going into, and just to mention, I think we've already went over some very high yield things that come up with these fractures that you'll see in different question banks. So I'm glad that we're spending a little time on just kind of the workup. But heading towards treatment, what factors do you take into mind when it comes to how to treat these fractures?
So the basic way to think about how treatment of pediatric femur fractures works is basically based on age. And so, if you go 0 to 6 months, basically most people, the evidence would say that you could do either a Spica cast or Pavlik harness, but that there's really no advantage of the Spica cast over a Pavlik harness. So most people will use a Pavlik harness. The ability of the femur to remodel at that age is remarkable. So there's really no reduction performed. And the Pavlik harness is predominantly for comfort measure while the femur fracture is healing. So, so that's 0 to 6 months. And then as we move forward, 6 months to, let's say, 5 years, we're basically looking at Spica casting being the gold standard. There's some that in certain situations, whether that be high energy trauma or, other psychosocial or social needs for the family, will consider flexible nails in some of the slightly older preschool kids. But again, the gold standard is Spica casting there based on the age criteria. And then age 5 or 6 to about 11, we would be looking at flexible nails. Okay, now if you read a book chapter, it'd be flexible nails for stable fractures and consideration of a submuscular plate for unstable fracture patterns. In my practice, it basically jumps from Spica cast to flexible nails to rigid nail. And we kind of skip over the submuscular plate for me. But there are other, and that's mostly here at our institution, and I know at some other institutions it's pretty flex nail heavy. There are other institutions and other surgeons, who have a bigger interest in submuscular plating. And then for kids that are bigger, and as we get into the adolescence, we're looking at rigid nails. Similar to adults, the only difference is that the entry point is slightly different, where we avoid a piriformis starting point due to the risk for avascular necrosis. So, for a general overview, that's that would be sort of the age-based treatment algorithm.
Okay. And if we could go back a little bit to, say, starting at the kid that's less than 6 months old.
Yeah.
So in the emergency department, mom is just, she is, she can't believe this happened. She's so sorry that she turned her head for a second and baby Joey fell off the bed or whatever may happen. Like, what are some of the things you're telling mom to look for once the kid is in these different devices like the Pavlik harness? What are some of the things that you may tell mom that, okay, this is how this is going to go, and we'll probably have him in this for how long and things like that?
Okay. So for somebody that's that young, honestly, they're going to heal almost basically in like 2 weeks. But I'd probably keep the Pavlik on. I generally keep it on for about 3 weeks, see them back in clinic, and we'll take it off. I emphasize that it's for comfort only. And, some of the positional issues, and I see that's on your slide, whether you use a Pavlik harness for developmental dysplasia of the hip, or if it's for a femur fracture, there are a couple things that you want to avoid. You want to avoid flexing the hip too much in a Pavlik harness, okay? And the reason is because if it's flexed too much, you can get femoral nerve palsy. The thing that we would notice with that would be that you'd have decreased quad function. So, a 6-month-old is not going to follow an exam to command, but, you observe them in clinic, and even in the Pavlik harness, they should be able to extend and flex their knee, and you'd be able to observe that. So that'd be one of the things that they would want to look out for. And then the other thing is, you don't want to have too much abduction fixed into the Pavlik harness, because if you have too much abduction, or if it's too tight, then that can lead to avascular necrosis of the femoral head. And, from my perspective, you got to keep in mind that, again, like I said from the beginning, when it comes to the Pavlik harness, our treatment is for comfort. So if the only reason we're using the Pavlik is mostly for the infant's comfort, we certainly want to avoid making it too tight, either too tight in hip flexion or too tight in abduction. So if anything, you would want this Pavlik harness to be, looser than it needs to be, as opposed, error on the side of it being too loose as opposed to it being too tight. Because unlike DDH, where you're kind of using the Pavlik to mold the femoral head and the acetabulum, and it's like being used as a tool, this is kind of being used as an ACE wrap almost, or a very mild splint. So, with that in mind, you certainly don't want to end up with a femoral nerve palsy or AVN.
Absolutely. And I saw one time, if you happen to have one of these kids that's just an all-star and for some reason they're like crawling at a really young age, you might have to think of something different than the Pavlik harness sometimes, just to keep them from, running around, crawling around like they want to try. So I only had that happen like one time, but something to keep in mind.
Definitely. So, but the other point to these kids is that these fractures heal very, very fast.
Which is so amazing to me. I think that's the whole, overall theme in pediatrics. I mean, you put a grocery bag around it and pretty much it heals itself.
Grocery bag.
Yeah, I mean, really, you put a Kroger bag on it, and I mean, give it a little time, and next thing you know, it's like brand new again. It's amazing.
If our ER runs out of Pavliks, I think maybe next time I'll try the grocery bag.
Don't get a Kroger bag.
Works like a charm. Works like a charm.
Well, different region. We'll tell the resident to run to Winn-Dixie.
There we go. There we go.
And so another couple of things I wanted to touch on were some of the complications or the things to be on the lookout for when we're spica casting these kids with these pediatric femur fractures. Like what fractures can go in a spica cast, and then what are some things we want to be on the lookout for when we're putting a spica cast on and with these patients.
So spica cast, basically, again, gold standard, let's say 6 months, and certainly as you're approaching a year, up to 5 years of age. What we're sort of, in terms of fractures that are amenable to a spica cast, technically pretty much anything, with the exception of I would say an open fracture, probably fix that. If there was a lot of soft tissue abrasion, say for example it was peds versus auto, and a patient was dragged on the gravel and you were really concerned about the skin, that might be a contraindication for a spica cast. But for the vast majority of those kids, it's at least appropriate that would be the first line treatment for kids at that age. In terms of fracture characteristics, we would like the fracture to be less than 2 centimeters of shortening, or about 2 centimeters of shortening. There's a little bit of debate with that, because some people will allow for almost up to 3 centimeters of shortening, before they get concerned about leg length discrepancy long term. And then angulation, for a 2 to 5 year old in the coronal plane, you can accept 15 degrees of angulation. Sagittal, there's more remodeling, so you can accept 20 degrees. And again, shortening, basically we use 2 centimeters as the cutoff, but certainly I have used a spica cast in kids with slightly more than 2 centimeters. And, with long-term follow-up, they did not have a significant leg length difference. In terms of the application, you want to make sure, obviously, to keep enough room for perineal care, diapering, things like that. You want enough room for the abdomen so that it's not too tight in the abdomen. The way we, ensure that is we'll place towels on the abdomen. I will typically also put 1 towel on either side, just because sometimes the abdomen will the cast over the abdomen will protrude and there'll be enough room there, but on the sides it's still a little too tight and the families will complain about that. So a way around that is just not a thick amount of towels, but 1 towel on each side as well. I usually will try to use a 1-leg spica that really facilitates earlier ambulation for the kids, care for the families. Sometimes with a single leg spica, the kids can even fit into a car seat. And so, I think there's some great advantages, and there's some literature to support that single leg spica works in the vast majority of these fractures, as well as a 1.5 leg spica as pictured on your slide. So I guess off the top of my head, those are some of the things I'm thinking about with spica.
And so, yeah, like you mentioned, I'm glad you mentioned that. We at our institution, we have to make sure that the kid has, first you have to go through kind of like training just for care with mom and dad. And then they have to have a special type of car seat. I don't know, kind of like an attachment before they leave.
Yeah, kind of like the one you sit in, Jay.
Oh, that was good, Cody. He's been saving that one up all night. All right, great job, man.
That was low. No, it's called he's probably sitting in it's called an easy-on vest. So there's this vest basically that can attach to the child if they can't fit into a car seat. So if you have a 1.5 or 2 leg spica and there's too much abduction and you can't fit in a car seat, you can use this thing called an easy-on vest, which basically straps around the patient in their cast, and then the seat belt somehow straps into the easy-on vest, and the kid sort of lays, as opposed to sitting up, they're sort of laying in the back seat. There are also, more recently, there are actual car seats that can accommodate spica cast patients. They're really expensive, but hospitals can buy those too.
Yeah. And just to like a little plug to my institution, this was one of those things that I was pretty nervous about the entire time I was taking call at the children's hospital, because in the middle of the night, this might just kind of be you and a few people in the emergency department who have no idea what's going on, so you have to kind of talk them through it sometime. But we have on ViewMedi, and some of you guys don't know what ViewMedi is, and if not, you should look into it. But some of my attendants have a awesome video on how to do these spica casts. It's like a 15-minute video on how to do a proper spica cast. And I mean, it got me through the night plenty of times. And you'll be surprised how many times you'll get these fractures over and over and over again. It happens pretty often, a little bit more than what you would think. So it's good to keep that in mind.
Sure, they're proud of you right now listening to this. If they are, I'm sure they'll be proud of you.
Probably either that or they be like, man, he looked at that video and the kid was still that cast was still that bad. Like, oh my
One of the
gosh.
two.
Yeah, one or the other. All right.
Um, yeah. So I'd like to. We can probably go ahead and move. I want to just touch not quickly. I just wanted to talk a little bit about the kids that we treat with the elastic nailing, and if Dr. Heffernan, if you could kind of just talk about what that is, what kids that or pediatric patients that we would treat using these nails, and anything, any tips that you would give regarding the nails, whether it's the canal fill, how you start the nails, or if there's a weight that you would stop and not use elastic nails to treat these patients.
Yeah. So for me, for kids that are 5 to, let's say, 11, I would say that's my go-to plan for almost every femur. In fact, when I started practice, I really wanted to do a submuscular plate. And in fellowship, I really wanted to find a case that I could do a submuscular plate on. And we really were able just to use flex nails for almost everything, including, unstable fracture patterns. In fact, in Journal of Pediatric Orthopedics last month, there was an article that was looking at stable versus unstable fractures and the use of flex nails. And they found that, and that was out of LA, they found that using flex nails for unstable fracture patterns was certainly a good option in their hands. And that's something that I've found as well. In terms of the concept, so, the ideal situation for a flex nail or a titanium flexible nail, is a mid-shaft femur fracture that's transverse. Okay, so that's sort of like the base of where we're starting from. And the way that you put the nails in is you sort of put a bend to the nails so that the convexity or the maximal separation of the nail, the two nails, occurs at the fracture site. And so it's the shape of the nail that sort of confers fracture stability, as opposed to, if you take a rigid nail for the older kids, it's the rigidity of the nail that confers the stability. But with flexible nails, it's actually sort of the shape and where that bend interacts with the bone, basically like a 3-point mold, essentially, and that kind of confers the stability. Okay, so that's your ideal situation. But then there's plenty of fractures that are either in the proximal third, distal third, or they're unstable patterns. And so there's some subtleties to that. One of the main things I guess I would point out is for proximal third fractures, I've found that if you look at the shape of the nails there, pretty much you've already passed the maximal convexity or the maximal separation, and the fracture, at that point, the nails are essentially straight. So they're kind of acting like just a rigid nail. So I've switched from using titanium nails for those fractures to stainless steel nails, because conceptually now I feel like the nail there is providing stability because of the rigidity of the nail as opposed to the shape. So that's kind of like one subtle thing that I've learned over time. And for those proximal third fractures, which can have some muscular forces on them that won't cause them to want to displace, what I originally did when I was using titanium nails for that, I occasionally would have to use a one-leg Spica cast to kind of supplement the nail for a week or two, just until the fracture got sticky because it really wasn't strong enough. Then I switched to stainless steel, and I've subsequently not had to put any cast on for those proximal fractures. In terms of the starting point, basically the predominance of these nails, we start both of them distally, and that's sort of like your middle picture there. You basically locate where the physis is on fluoroscopy, and you want to go about 2.5 centimeters proximal to that for your starting point. I use an awl. Some people use a drill in order to create the hole in order to pass the nails. I will pass both of the nails from both medial and lateral sides up to the fracture site, and then we start working on reducing the fracture. Once the fracture is reduced, I'll start passing the nails. And one thing about passing those is similar to reaming for a rigid nail, you kind of have to have the fracture reduced. It doesn't have to be perfectly reduced. And in the book, you'll see like this, or you'll see it described where you kind of use the flexible nail to do the reduction. What I've found is you can tweak the reduction with the nail, but if the two pieces are totally off and you just randomly get one of the nails from the distal fragment into the proximal fragment, but they're nowhere close, the nails are not strong enough to actually do the reduction. You have to have it pretty much reduced before you pass the nails. And I guess that's it. Is what I would start with. We try to do those closed. Occasionally we have to open the fractures. We just published a study recently that looked at fractures that had to be opened when trying to do the fracture site open when doing flexible nails, and we found that high energy trauma, initial displacement, and distal third fractures were more likely to be opened. Before I open the fracture, I'll try some other stuff. For example, using Steinman pins in either of the fragments to try to get control and try to get a reduction with that. But occasionally we'll have to open the fracture site to be able to pass the nails.
I think that was an excellent review on talking about nails, these elastic nails, how to use them, the approach, how to, even the technical parts about how you align or reduce your fraction and get the nails up. And one thing I wanted to touch on was that it kind of say what the nails, you wanted to fill up about 80% of the diameter of the canal when you're using these. Is that correct, or is that something that you've kind of seen in your throughout your practice or your knowledge?
Yeah. So, and I'll touch on that in one small technical point. So the general thing that you look at is you measure the isthmus, which is going to be the most narrow aspect of the shaft. You can measure that on the AP and the lateral. They usually should be the same. I usually err on the one that seems bigger. And then you multiply that by 0.4, and that should give you the size of your nail. So basically, you take the isthmus, and our goal is kind of to fill 80% of that, okay? There are some more recent studies that looked at fractures where you had 80% or greater fill and then less than 80%. And even if you have less than 80%, I can't remember the exact percentage, but it's pretty low to where you start getting increased complications. So we always shoot for the 80%, but if you don't quite get 80%, you're probably still going to have a successful outcome. So again, if I'm sort of in between sizes, say for example, they come in 0.5, in terms of the millimeters. So you have 2, 2.5, 3, 3.5, 4, 4.5. If I am in between nail sizes, I usually prefer to go down a size and use a stainless steel nail, as opposed to trying to stuff a bigger titanium nail in. So one of the issues is, if you try to overstuff the isthmus, and especially if that's right at the fracture site, that can make passing the nails pretty difficult. And again, the stainless steel nails, because they're a little more stout or have a little more firmness to them, you can confer essentially the same stability at the fracture site with a slightly smaller nail.
These are perfect. I mean, you can't get these types of pearls unless it's from somebody with a lot of experience. So we appreciate you dropping all these gems on our podcast. It's going to help someone for sure.
Oh yeah,
But
I wish I had this
that being
before.
said, if it's a test, it's isthmus size times 0.4.
Right. That's good to know too, right? There's test answers, and then there's actual clinical practice. So we have to separate the two sometimes. So when do we use the the intramedullary, the same type of nails that you would consider for like adults? When do you start making that transition in the kids? And also, is there any differences that you have to keep in mind, like starting points and things like that?
Yeah, so I make that transition in the teenage years. And I guess there's not a specific age for me on that. And similarly, on the other side, for flexible nails, I routinely use them over age 5, but I certainly consider them in some kids as young as age 3. But on the other side, I think the oldest and or heaviest, let's say heaviest child that I put flexible nails in, I think was probably like 11 or maybe 10, but weighed 160 pounds. So the one thing we didn't cover is historically the weight limit for flexible nails has been thought to be 49 or 50 kilograms, so about 100 pounds. There's been more recent literature that supports using flex nails in heavier kids, and I've definitely done that and been successful. But as the kids start becoming teenagers, and that's variable, right? Kids, skeletal maturity, their size, not all 11-year-olds are the same. Not all 12-year-olds are the same. So there could be a 12-year-old that I put flex nails in because they're so small. But there could be a 10 or 11-year-old that, according to the age criteria, we'd first consider flex nails, but I end up using a rigid nail. So I guess the transition, if you forced me to say, where does that transition fall? I guess 11 or 12, but there's some gray there. In terms of starting point, positioning is very similar to adults. So some people use fracture table, and I occasionally use a fracture table. And some people use flat top tables and assistants to sort of hold and pull. And I also do that. And I actually picked that up from residents where Cody's a resident. Wendell, sorry.
Yeah, no, either name.
And so that's for positioning. In terms of start point, we start a little more lateral. So in adults, there's still troch entry nails, but people also will use piriformis start points. In kids or in folks who are a little bit more skeletally immature and or, smaller proximal femoral anatomy, we're a little bit more concerned about ABN. And so we end up using a more lateral start point, meaning even lateral to the tip of the troch. So, really to avoid that. I think the rate of osteonecrosis in the literature is probably, I think it's around 5%. So, and that's kind of a devastating complication. So we definitely don't want to see that.
I guess I didn't realize it was so high, to be honest. I always thought that it was one of those things that are, it makes sense that it will cause, a vascular necrosis, but it wasn't actually being seen a whole lot in the literature. But yeah, that's good to know that. Because 5%, that's a lot to deal with in a young kid, because now you have some real issues that you're going to have to work out, and probably have to have a couple, at least one other surgery to try to fix this issue. So yeah, it's definitely good to keep that in mind, and it's very high yield for, in question banks and things like that. So definitely need to keep that in mind when doing questions and things like that.
Yeah, from a question standpoint, it's basically, avoid piriformis starting points in pediatric patients or young adolescent patients because of the risk of osteonecrosis. And the percentage, I think it's 5%. You guys would have to look that one up. But it's enough, and even one would be terrible. So,
right. At the end of the day, right? Even if it's that 1%, you don't want it to be your patient or your child. So, absolutely, it's definitely worthwhile of trying to avoid that if best possible, for sure.
And are there, before we wrap up here, are there any complications or things that we should be on the lookout for long term in these pediatric patients that end up having these femur fractures, that end up getting nailed with either flexible nails, retrograde, or possibly our anterior grade? rigid intramedullary nails?
So I guess we'll go for each one of them. We talked about some of the complications with Pavlik, that being femoral nerve palsy, AVN, spica casting. In the short term, there's issues with cast. You can have skin complications. In theory, there's reports in the literature of compartment syndrome, full thickness skin loss that required, plastics intervention. For kids who have some shortening, I usually will follow them up to 2 years to make sure that there's no permanent effect from that, and that they've sort of, equalized out or gotten close enough. The rate of overgrowth, the reason we're willing to accept some of that shortening is that it's been shown that there's the potential for overgrowth with the fracture, and that's about a centimeter. It's just under a centimeter. And so that's something to keep in mind. So leg length discrepancy is one of the things. With flexible nails, the issue is, in the literature, it says that, there's a pretty high rate of implant irritation. I really haven't seen that in my practice. So, I've seen as high as like 30-40%, but it's very rare that somebody actually complains of implant irritation. But that's one of the things to look for with flex nails. Submuscular plating, generally speaking, depending on the age, both the flex nails and the submuscular plates, we're likely going to take those out just because of the growth potential of, like a 6 or a 7-year-old. If the femur grows a lot and, now all of a sudden the end of the nail or the end of the plate is in the mid shaft, it's kind of creating a bad stress riser. So routinely we'll take those out. Submuscular plates are pretty easy to put in submuscularly, a little bit more difficult to take out. And so that's, one of the reasons I kind of shy away from the submuscular plates. And yeah, I think that's, I guess, rotational malalignment. Again, these kids have a lot of remodeling potential. I guess malrotation is not supposed to really remodel, but again, just from my clinical practice, I haven't seen a lot of malrotated femurs that we've done, whether that be in a spica cast where, we're not really controlling the rotation that much, flexible nails where we don't really have that great of control of rotation. And the rigid nails, obviously we do our checks as we should in the operating room and kind of confirm that we have good rotation before we finish the case.
All right, Dr. Heffernan, I think we've done it. I think you've done it. I think we went over a lot of high yield topics on femur fractures in pediatrics. I think we hit on a lot of things that you'll see on your tests, that you'll see in the emergency department, that you'll see in your clinical practice. So I really want to just say thank you for coming on to the show and dropping all this good knowledge for us.
Gentlemen, I appreciate it. It's almost 11 o'clock your time, Jay Fitz. So
it's okay. The grind never stops. The grind never stops.
I like it.
Well, I think you guys are great, and I love this thing that you're doing.
Absolutely. And before you go, Dr. Heffernan, we always ask our guests, is there a way that our listeners can reach out to you, whether it's your email or maybe some of your social media handles or anything like that you have available?
Sure. That's funny. One of Wendell's co-residents convinced me to start an Instagram. So
there we go.
Dr. Hef Ortho is, I guess, my handle. I guess.
Oh, you changed it.
Why? Yeah, it was Mike Heffernan MD before, but now it's Dr. Hef Ortho.
Ah, okay.
And then my email, people can email me. It's mhef1@lsuhsc.edu.
Awesome. Again, everyone that's listening in or watching on YouTube, thank you guys for spending time with us, and see you back next week. Take care.